Sunday sermon, and have I got something special for you, particularly as I come from a somewhat Catholic upbringing. Today we are going to get into I don't know if it's going to be really Adam and Eve, but we are getting into the black snake whip. And notice, white chalk. Yeah, if I did black chalk on a blackboard, probably not going to see what I'm talking about. However, today, the black snake whip. Did you know it's the #1 Google searched foot manipulation, mobilization, manual therapy technique that's searched? Do a Google and you'll see what happens. There's a lot of people who have a lot of interest in it. I know our history of teaching and training manual therapies, of foot mobilization therapies and high velocity manipulation. The black snake whip is the #1 technique that everyone wants to be able to master. And hell, with a name like black snake whip, how sexy is that? Feet mobilization, maybe not so, but black snake whip, it's a good one. If you are a master or would like to be a master of the black snake whip, give me a thumbs up and then I will carry on. Well, I'm going to carry on anyway. So, we're going to cover some key elements in this session. You're going to learn about the clinical clues of when you should actually do the black snake whip. We're going to do the clinical tests. We're going to go show you the actual actions and some of the end range qualities that you need to be mindful of. And I am so prepared. Don't watch this. Talk amongst yourselves, because I needed one extra special prop that I almost didn't remember. Okay, so first of all, with the cuboid, from a clinical perspective, be mindful of the fact that anyone who's had a history of ankle inversion sprains, you'll find that the prevalence of cuboid compensation post-ankle injuries, post-ankle inversion sprains, is incredibly high. The evidence research very clearly tells us that following ankle injuries, we've got cuboids that get involved secondarily or even in a more significant manner. So how many of your patients, let me ask you this, if you've had a patient who has ever in their history rolled their ankle, give me a thumbs up. And I just want to see how many thumbs there are, because I reckon that every one of us, probably the tougher question is, can you think of a patient who has not rolled their ankle sometime in their lifetime? And the reason why I'm saying that is because it happens a lot. And therefore the commonalityness of how many people get cuboid problems is right up there. Okay, we're up there. Well, look at the ceiling. Yeah, okay. I am 3 meters tall, so that's why I can reach the ceiling. Okay, now, one of the key reasons why I really encourage you to master assessment and treatment of the cuboid is because, one, with the prevalence of how many of our patients have cuboid problems, but the other is how much your orthotic outcomes can be improved through getting the cuboid, the amount of compensation or side effects of cuboid and lateral foot problems, get that reduced, it improves your orthotic outcomes. Do you use cuboid notch pads for the cuboid? Do you use those in conjunction with your orthotic devices? Maybe you're just on a plain insole. If you do, give me a thumbs up just to make sure that I know I'm speaking to the right audience here. I know certainly in my experience that most practitioners with lateral foot problems have cuboid highlighted in their orthotic prescription for managing and helping patients with that. If you only remember one thing, okay, it's going to be Ted's tip. I'll put it up on the board because this is so important, is we're going to, if you only remember one thing from this video, is when you use a cuboid pad, the objective is the common displacement pattern of the cuboid is in an everted direction. So what happens is the base of the plantar surface of the cuboid ends up facing away from the midline, eversion. So therefore the treatment option is going to be to invert. Make sense? Thumbs up, let me know if that makes sense for you. That is the key element, and that's the purpose of what you want to do with your cuboid pad. Now, I can tell you this, that if you did this right now, no, don't do it right now, but do it after this video, do a Google search on cuboid pad. And what you'll find is that all the cuboid pads get positioned underneath the mid part of the cuboid or even the lateral part of the cuboid. And what that does is actually increase the eversion, moment onto the cuboid. So if you only remember one thing, go more medial, so medial 2+, and you'll end up in the middle of the foot. If that's all you do, just do that on your next 6 cuboid pad patients and see what happens. Particularly with those patients that you've had where you put a cuboid pad in place and the damn thing got worse when they came back for their follow-up. If you've ever had that happen, just keep that silent because we don't want to let other colleagues know that. But I've got to tell you, it's happened to me. I thought, what the? How did that happen? And that's when I understood, we've got to invert the cuboid. All right, so clinical clues. What we're going to do with the clinical clues, make sure that you, first of all, you know when patients complain of cuboid-related problems, the site of actual symptoms can be very difficult to specifically isolate. And that's because the cuboid articulates with 1, 2, 3, 4, 5, 6 bones, as well as all the ligaments, capsules, you've got tendons, peroneus longus, you've got the extensor tendons, you've got all these structures here that can be affected by cuboid compensations. So the actual specific site that a patient, you say, where does it hurt? And they kind of go around here somewhere. You'll find that may not be such an easy thing for you to isolate. And that's just because of the anatomy that takes place here. The other important clinical test or clinical indicator is when you palpate on the plantar aspect. When you palpate on the medial aspect, that one of the transverse ligaments on the cuboid, what happens is it often develops a trigger point, tender point, and you press on it, and it's exquisitely tender. It's not just the pressure you're putting on there, but when your patient winces or flinches with that, that's a very important clinical clue that they've got a cuboid compensation problem happening there. Also, if your patient has any history of fibular or perineal troubles, this is really important to be focused on the assessing the cuboid too, because of peroneus longus and peroneus brevis. And when there's compensation here, it can affect the attachment sites or the origin sites of the peroneal muscles. So there's some key clues for you. Clinical tests. Well, if there was only one clinical test you would do, Paul Graham down in Geelong, I hope you're listening and watching this because I recall your message from just yesterday, and that is the cuboid assessment test. So let's just have a look at Scully here. He's having a little bit of a lie down. He's also going, la, 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 not listening, up this guy again. Why do I have to work on a Sunday? Scully, it's triple rates. Stop your complaining. Okay, so with the cuboid, the cuboid assessment test. I got you upside down, Scully, so let me demonstrate this way. What the cuboid assessment test is if there's a displacement or a dysfunction in the cuboid, it affects the articulation of the base of the 4th metatarsal and the 5th metatarsal against the cuboid. And what the result of that would be is that the ability for those metatarsals to dorsiflex at this joint articulation is compromised. So what we're going to do is we're going to stabilize all of the joints around the foot as much as we can so that we can isolate this articulation between the 5th metatarsal and the cuboid. And then what that will tell us, in a clinical setting, the patient will be in a supine position. Thanks Fitzy for that correction on supine and prone, and now she's given me a very good description of how to remember whether someone is prone, and that's because if someone's prone to being up the arse, then that's the prone position here, but I'm not sure if that's going to make it past the editing suite. Okay, so what happens is, imagine you're the patient and this is your foot, and you're thinking, I need to build up some muscle power here. I'm going to, as the practitioner, stabilize the rear foot, the ankle, the subtalar joint, and I will literally do that with my medial hand. lateral hand is just going to grab hold of the fifth met head, and from the resting position, I'm literally just going to dorsiflex the fifth met head. Now, what that will do is, if there is normal articular relationships between the base of the fifth metatarsal and the cuboid, it will move freely and easily. You'll feel the quality of movement, and the freedom of movement works perfectly fine. However, if the cuboid is displaced or dysfunctional in some way that's affecting the articulation, you'll go to dorsiflex and nothing. There is no movement. And literally, it's like the bones are kind of jammed into each other and you can't get that dorsiflexion happening. If you're familiar with this cuboid assessment test, please give me a thumbs up. Andrew Baldwin in Melbourne, if you're watching here, I want double, triple thumbs up from you because you know the importance of this test. Andrew's a sports medicine physiotherapist specialist working with a lot of orthopedic surgeons, and this was a transforming test for him. So that is really great news. Okay, I'm going to say, Dr. Lily, you're smiling at me and looking gorgeous.
Alison.
Fitzy, good to see you there. And for those of you who are wondering who's holding the camera, well, let me turn the camera on. No, she's not going to let me do that. Dr. Lily is here helping out, making sure that you get some quality education on a Sunday. Okay, so stabilize the rear foot, stabilize the ankle, stabilize the subtalar joint, then dorsiflex. If it moves, great. It's probably not a dysfunctional cuboid. If it's blocked, then you need to release it. There's a cuboid mobilization that works really well. Today though, as promised, we're going to get hot and sexy and we're going to get into the black snake whip. So your patient is going to be lying in a prone position, Fitzy. Prone. Yes, I'm prone to ballsing this up. Okay, so we've got Scully, not talking, not contributing. I think I got a bit of a bone to pick with him. Okay, so we're going to recall how I talked about the inversion moment is the effect that we're after. And what we're going to do means the contact point. Remember, position and precision are your keys to mastering manipulation techniques. So you'll place your medial thumb on top of the medial aspect of the cuboid. Your lateral thumb will be reinforcing your medial thumb. And then your fingers just wrap around the dorsum of the foot. Then we are going to apply a high velocity force on that medial aspect. To gather momentum, we would literally swing the leg around, and at the base, we take up the tissue tension and just flick into it like so. So I'm doing this in slow motion for an instructional purpose. However, if there's only one thing that you remember from mastering this technique, it comes down to this. And what that means is, this is a great analogy of, this technique is all about timing. So, remember the days when you were at school and you would do that whip? Notice how the first one didn't work, but the second one was a little better. Why? Because of timing. That is the key. Another tense tip I got for you here is the 95, 4, 1. 95, 4, 1. You add those up, what do you get? 98. Congratulations. Or maybe you get 100, because this actually relates to percent. And to master manipulation techniques, 95% of the effectiveness comes from the setup. This is crucial. 4% comes from timing, and 1% is the physical force. So when you do a towel flick, it's all about the setup and the timing. It's not so much about the force. Dr. Brian Power, physical therapist, PhD, specializes in neurophysiology as well. Did some great training with Dr. Brain. It's just a typo that autocorrect does for Brian. So Dr. Brain was telling us that this is the crucial key, setup. And this is what we go through in detail with our foot mobilization therapies workshops and the high velocity trainings. You gotta get the setup right. And the difference of thumb position from the middle of the cuboid to the medial aspect, you'll see it's 4 millimeters. But that difference makes all the difference. So it's just the one simple distinction, but that's the key rule for high velocity techniques. We'll be doing our high velocity training, extra advanced training in Byron Bay. What a gorgeous part of the world, end of August. So if you're an FMT1 graduate or about to be, consider that, pencil that into your diary. Okay, so we have, once we've got the actions, keep myself decent here, and we go through literally that whip action, and you can repeat that 2 or 3 times. Often you'll get a cavitation or an audible release. That's that release of built up gases within the synovial fluid around the synovial joint. We get that release. What that does, again, great thanks to Dr. Brain for helping me understand the neurophysiology, is it dramatically helps, it inhibits the inhibitors. What I mean by that is the perineal muscles and tib post muscles as well that stabilize around the rear foot and stabilize the foot onto the leg, they can be inhibited through mechanoreceptor dysfunction. So what the cuboid black snake whip does is help inhibit those inhibitors, which means it releases the inhibition so that the muscles can be neurologically strong. It's nothing to do with muscle strength per se, it's about the neurological input. You can literally alter the position of the cuboid and make the perineal muscles weak or strong. It's one of the clinical tests that we do before, so you've got a reference point, a baseline of whether you actually need to do a high velocity technique. So that's all part of the advanced training that we have lots of fun doing. In fact, one of our practitioners who did do some advanced training, let me just pull out something here, something I prepared a little earlier. And this is coming from one of the cuboid queens, which they seem to be really populating around the UK. This is from Mary Moore in Ireland. I know it's not the UK, but Mel South, she is also the queen of cuboids. But Mary has a great experience. She sent me this message. Hey Ted, I had a very successful resolution of a cuboid problem last week. The young soccer player, not AFL football, although I don't want to talk about AFL right now because the Adelaide Crows had a shocking start to the season yesterday. Anyway, the young footballer's condition had puzzled 2 eminent orthopaedic surgeons. The young man had a 2-year history of pain. MRI was inconclusive, so he ended up taking up boxing as there was no symptoms when he was on his toes. Yeah, that's got a safe option. Okay, luckily a podiatrist in Cork referred him to me. After just 2 sessions of foot mobilisation, including the cuboid manip, the black snake whip, the patient's pain has gone and his foot posture has returned. Thank you, black snake. Now, great result, huh? Orthopaedic surgeons, look what Mary can do. Anyway, 3 months later, Mary then sent me a follow-up, and that is the patient was a GAA senior player. It's one of the high leagues, football leagues, soccer leagues in Ireland. Got a lovely thank you card from him. He still can't believe that he is able to play football again at such a competitive level after 2 years of only running in a straight line. Imagine if that was your patient. Imagine the impact you can have with your lateral foot or cuboid related problems. Those patients who, you kind of get better but not best, or you just don't seem to make some headway. If you're not able to use high velocity releases for cuboid techniques, imagine the difference it would make having that in your toolkit. The cuboid release is actually the first high velocity technique I ever saw professionally demonstrated by Dick Bogdan back in, must be 85, 86, the running foot doctor, sports. He was one of the first sports podiatrists around. And it just like, how did you do that? It was a number of years until I found out how to actually do that. Right now, you can look up YouTube and pick it up yourself and work it out yourself. And I wish you well if you choose that option. The resources are out there. I tried to do that and it didn't work for me. I really needed direct training from someone who knew what they were talking about. And that's why now we concentrate on training practitioners in manual therapies, because we know the impact and the difference that it makes on your patients' clinical outcomes and the results in their lives. And I've got to tell you, from your perspective, your personal and professional fulfillment, as well as your clinical confidence, really get a nice boost as a result of mastering this type of technique. So, if you're interested in following up any manual therapies training, we've got courses running in Australia at the end of this, in May and June, FMT Level 1. Our early bird special offer, where you can save $500, ends next Sunday. So if you're going to get on board, now's the time to get into it and make sure you save yourself some decent cash. Big shout outs to Craig, Taslim, who's making her way all the way down from Canada to join us in the Australian trainings. I don't want to hear any bitching from anyone saying, oh, I can't travel so far to Melbourne, Sydney or Brisbane, because I'm just going to say, hey, Taslim is doing it, other practitioners, so we've got a number of international practitioners coming through from all parts of the world. So it's great to be amongst your colleagues enthusiastic about developing their manual therapy skills. And if you don't come, I'll probably have a bone to pick with you. If you thought that was hysterical, you better put a smiley face, laughing face. And if you thought, oh, Ted, dad joke, shocker, yeah, maybe a sad face or a thumbs down. Not that you can do those. Okay, coming to you next week. We have lots of exciting lessons, but specifically tomorrow, on Monday, it's going to be Monday mid-tarsus. Just made that up right then. A bit of alliteration. We're going to focus on the cuneiforms. These are joints and bones, those mid-tarsal osteoarthritis cases, the ones that affect the forefoot. It's lots of really good stuff going to be coming to you tomorrow. So tomorrow will be mid-tarsus. Today, you got the cuboid. And coming up through the course of the week, we're going to cover all the other bones in the foot as well. Any questions? Type them in the comments box. Any comments, observations, in particular, if you want to make an assessment and rate my hair out of 10, you're welcome to do that as well. But I'd probably be more encouraging you to say questions about what's happening with Footwise would be fabulous. Thank you very much for being part of today's Sunday service. May I bless you, your feet, and all of the family and your clinical staff and team and clients. Oh, geez, I'm really putting my foot in it right now. I'm wrapping up. Till next time, serve with spirit, consult with care, and cure more cuboids today.